The next part of the exam is the abdominal exam. And like any exam, appropriate draping is necessary to make sure to preserve modesty, keeping parts covered that we are not going to examine, and also for warmth, of course, if you're in a cold examination room. So Eric, I wonder if you could raise your gown. I'll hold the sheet here.
Okay.
And raise it up just about to the lower end of your chest. All right, and then I'm going to have the sheet down at the lower end of the abdomen for maximum exposure of what I need to look at. Then, now if you can bend your legs in half and rest your feet on the table. Now this is the best position for the patient to be in for the abdominal exam. Arms at his side, legs bent. This relaxes the abdominal musculature and allows us to perform our exam, particularly when we get to the palpation part of the exam. But the first step is inspection. So with inspection, there's a couple of things you look for the abdomen. Always the surface areas or the surface of the skin, and make sure there aren't any suspicious looking moles. But with the abdomen, if there are dilated loops of bowel, you can sometimes see distension of the abdomen, where the abdomen sticks out a little bit more. Sometimes you can also see pulsation of the abdominal aorta, usually just above the umbilicus. You don't always see that when the patient is laying and breathing quietly. You also, of course, look for tattoos and piercings like you do anywhere else with the exam. So once I've started or finished with inspection, I'll next move to auscultation. Now, as you know, this is out of order of the usual techniques. The reason that we're going to auscultate next, right after inspection, is because I do not want to disturb or move the bowels around, which can artificially create bowel sounds. So there's been no palpation of the abdomen, but we're going to move right to auscultation. And what I'll do for auscultation is I'll press my stethoscope, the diaphragm of the stethoscope, in one area of the abdomen and listen for bowel sounds. If I hear bowel sounds, I know that the rest of the abdomen or the rest of the intestines are functioning appropriately. So as soon as I hear bowel sounds in one area, then I'm done. I no longer need to auscultate other parts of the abdomen. But if I'm listening in one area of the abdomen and I hear no bowel sounds, after about 20 to 30 seconds, I'm going to move to another location on the abdomen, again trying to listen for bowel sounds. Bowel sounds are usually easy to identify, high-pitched, medium-pitched, about 5 to 34 per minute or so. So once I've listened for bowel sounds, my next portion would be to listen for bruits. And just like in other parts of the exam, listening with the bell of the stethoscope is the best way to listen for bruits. The aortic, listening for aortic bruits is just above the umbilicus in the center of the abdomen. Then moving up into the right and left upper quadrants, just under the rib cage, is where I would listen for renal bruits. So I'll again have my stethoscope in, check, make sure I'm using the bell. Listen just under the rib cage on the left upper quadrant. Again, letting several beats of the heart pass, listening in the right upper quadrant, and then again listening just above the umbilicus. And the only sounds that I should hear are bowel sounds, and occasionally you can hear closure of the heart valves, but you should not hear any extra sounds beyond that, because those may indicate abdominal bruits, which can go along with atherosclerosis. So after I'm finished with auscultation, then I'll next move to percussion. And percussion is best used for both the liver and the spleen to determine size of the liver and size of the spleen. I'll first start with percussion of the liver. While the liver sits in the right upper quadrant, sometimes it extends below the rib cage, and so I'm going to start about halfway down the abdomen with my percussion in the midclavicular line and move from a very inferior location up towards the liver on this side here. So I'm going to start low here, and you can hear that. That's tympanic. It sounds very much like bowel. Now you can definitely hear a change here, from here to here. You know, definitely we're over a solid organ in this case, so I want to find the exact edge of the liver, and I'll start my percussion just as I did. Right there is where the sound changes. So the edge of the liver sits right at the edge of the costal margin here, as indicated by percussion. Now I want to find the top edge of the liver because then I can measure the liver span to determine whether it's large, normal, or small. So I'm going to continue percussion. And right there you hear a change. If I go up one intercostal space, you can definitely hear a difference between that and that. This is the liver. And right there is the edge of the liver. So the liver runs from this bottom, from the inferior end to the superior end. And I can take my ruler and measure, and I can see that his liver span is 10 centimeters, which is normal. So now I know the size of the liver, I'm going to check the size of the spleen. And what I will do is I'll go right at the lower edge of the ribs. You can palpate the edge of the ribs here, find where the lowest intercostal space is, and tap. And you hear that sounds fairly tympanic. Now what I'm going to do is I'm going to ask Eric to take in a deep breath as I'm percussing, and I'm listening for a change in the sound to something that sounds rather dull. If there's a change to a dull sound, that indicates that the spleen is large. If there's no change in sound or very little change, that indicates the spleen is not large. Because what happens with the spleen, as he takes in a breath, the diaphragm pushes the spleen up and out towards the umbilicus, and that will change the sound from tympanic, sounding much more like abdomen or lungs, to sounding like there's a solid organ in that case. So we'll try that. So I'm going to be tapping, and then I'm going to continue to tap as I ask Eric to take in a deep breath and let it out again. All right. Now there was a little bit of a change in the sound, not much, but a little bit of a change. Now there's going to be further tests that I'll do that will look for a large spleen, but if you heard that, there's a slight change in the sound, and that's what you're listening for, is a change from something that's tympanic to something that's dull. Now I finished with percussion. Now we'll move on to palpation. Now there's two different techniques to palpation. One is light palpation and the other is deep palpation. What light palpation does is just gives me a sense of whether there's any abdominal tenderness. Light palpation does not tell me what's underneath my hands as much as it tells me, is there an area of tenderness? So what I'm going to do is I'll palpate just kind of using a dipping motion with one hand. I'm watching Eric's face to see if there's any sign that he's in pain because he might grimace. I'm pressing and covering the entire abdomen here. While there are 4 quadrants, you want to cover the geography of the abdomen with that light palpation technique. Then moving more to deep palpation is to sense, are there any organs that are enlarged? Are there any abnormal masses? I already know where the edge of the liver is, but is there anything else in this area that I'm going to be, that I can palpate? So one hand is going to be pressed on the abdomen. That'll be more of a sensing hand to tell me what's underneath. And my other hand is more of the pressure hand. And the top hand is applying pressure while the lower hand is sensing whether there is anything abnormal underneath. And so I'm pressing again in all the quadrants again, but using a deeper pressing technique. Now there was no tenderness with light palpation, but I would continue to watch Eric's face and to ensure that there's no grimacing or change with deep palpation. The other thing that happens as you palpate someone's abdomen with pain is guarding, meaning that they'll start tensing up their abdominal muscles. And that's something you can sense and can be a sign that there is some pain caused by your exam. So once you've checked with light and deep palpation, then I'm going to check edge of the liver. I know already by percussion where the edge of the liver is, but I'm going to check its characteristic along the edge if I can palpate it. After completing light and deep palpation, then I'll move into palpation of the liver edge. And this is a technique where I'll use my left hand to lift up on the flank of the abdomen. This is in the back, and I'm lifting up just on the lower edge of the rib cage and using my right hand to palpate in the right upper quadrant. And what I'll do is I'll ask Eric to take in a deep breath and let it out. As he lets breath out, I can move my hand deeper into the right upper quadrant, right under where the liver sits. So take in a deep breath, and now blow it out. And as he's blowing out, then I'm taking my hand and pressing down into this area where the liver sits and checking to see whether or not I feel the liver edge there. All right, then I'll repeat that technique for the spleen, where in this case I will take my right hand, place it underneath the flank, take my left hand, press again in the left upper quadrant, ask Eric to take in a deep breath. And in this case, when he takes in the breath, that's when I'm going to be palpating because I'm trying to get the spleen to move out towards me. So I'll palpate, take in a deep breath. I'm going to be pressing here to see if the spleen is coming at me. Now let it out, your breath out. I'll continue to press to see if I find any abnormalities there, and there's nothing there. Remember before with spleen percussion, I thought there was a little change in the sound, but I do not feel an enlarged spleen as I palpate and do the deep palpation in this area. Now for the last part of the abdominal exam, I'm going to palpate the abdominal aorta. This is fairly deep in the center of the abdomen, and what I will need to do is use one hand to find the aorta. So I'm going to press fairly firmly. This might feel a little uncomfortable because when you're pressing on the aorta, it feels a little uncomfortable to patients. I'm going to press down deep until I feel that pulsation, very much like other pulsations that you find where you need to press and apply fairly good pressure. Once I find where the aorta is, I'll use both hands to move to either side of that particular pulsation and find where the edges are, using my fingers to find the edges of the aortic pulsation. And then I know the size of the aorta, and the size should be fairly small, 2 centimeters or smaller in diameter. And as I press my fingers on either side of the aorta, I can get a rough estimate of whether that's normal in size or not. And that concludes the abdominal exam.